do some research to help support, what I'm saying. But more importantly, what I am saying and sharing with you is through my evidence-informed decision methodology and what works in my hands and what has been successful for me. So I welcome any compassionate debate about concepts or other things that you can bring to light as well. But I do think it's important that you know that there are no conflict of interest. I don't work for any of the companies. I might give them my opinion. How can a Greek not? Okay, so ahead of the session tonight, I had also asked just to help with conversation and getting accustomed to new language, the resources for the American Academy of Periodontology, which of course is perio.org website, and they did recently just change their platform, so it's a little different, but it's still the same. You still find the tab that says member services, and you can then find the proceedings of the workshop that happened, and there's lots of resources there that are printable. We have them laminated for the students. So I have mine in my practice. So this is not an expectation for you to have it memorized in your head and just, I still have it in a perio office where I've been forever, right? It's there by my side if I have to reference back to it. So feel free to do the same. And then also what I really do like is, so those are the resources, one resource that you can print out, you can double side it if you for your staging and your grading and things like that. But also what's I find extremely helpful, maybe a little bit more than the AAP, sorry, my American friends, is the European Federation of Periodontology. They have great resources. They have short snippet videos to explain the contents of each of the classification. They do a great job. They also have what they use instead of kind of like just the mapping of the staging and grading. They also use kind of a decision tree is what they call it. So to help you make those decisions and fall someone into a classification, and then of course ties into, well, what is the modality of care when they fall into this classification? So great resources for you. Those two in particular, for sure, are great. Now, here back to our ADPI process, which I'm sure we are drilled into our heads and forever imprinted. But I want to kind of touch base, and we obviously know our ADPI process. I've added a few things to, to have a conversation about later on, but in our assessments, we do our clinical parameters, and it is indeed extremely valuable that we do our clinical parameters for sure. But I want us to kind of take a moment to reflect on what does this data mean? And it all ties into the classification as to why a new classification was introduced. But I want us to take a moment to kind of reflect on, what is it that we're trying to achieve? And I think, unfortunately, and we know the crisis that we're having right now with our healthcare system. I kind of stopped there because I don't normally say healthcare system. I usually call it a sick care system. And I think right now it's very clear that the system is broken and we need to rethink. So I think it's a great opportunity for us as healthcare practitioners to be really supportive of our patients and even be more diligent. I'm not expecting you to wear a different scope of practice and go out of your scope of practice. But if there were things like you didn't take blood pressure readings in the past, maybe this is a time that we do so that we can help, because we see the patients most likely more often, or if you're in a community setting, if it's not something that you normally do, then it could be something just as simple as that to help an individual get at least identifying that there might be a concern. Now, to get a physician, I don't have quite a solution there if they indeed, but I do think that we need to start acting more in a proactive way versus always being reactive in care. And this ties in, and this analogy that I use is exactly what I think are challenges, even in dentistry, even still in our curriculum at the university. So you have, we always tend to kind of want to go into that reactive of the symptoms. We take our clinical parameters, we spit out a classification, and then we jump right into therapy. And I think especially now, and especially there's a lot of people that are heightened about knowledge about their health. So it could be a good opportunity to tap into that energy, what good, or, if it's mental health, or they just are now really eager to learn more and be healthier. So wherever they fit. But it's to try to kind of make sense of like, what is this person representing with? So the example here is you have a fever and all the symptoms, right, could be different or similar, but the end result is that they have a higher than normal body temperature. However, so example, when they come in and you take your clinical parameters, they all have attachment loss, for example, or they all have caries. However, how they got there, their attachment loss or caries, can be very different to the etiology for that individual person. So the example here, well, you could have a fever because you had an allergic or just allergies or an allergic reaction, or you have COVID, or you have cancer. And how you are going to do your care plans, in other words, treatment plans, I don't like the word treatment, so I call them care plans, is going to be very different depending on what actually is that individualized representation for that person. So when we bring it now into the world of our world of oral care, then what is it that is, although the symptoms or the end result is very similar, for all these individuals here who all have a level of periodontal concerns, we'll call that, how and why did it get there is really more important now than simply having clinical parameters and spitting out a classification. Because again, we jump into reactive care, we start doing debridement. Don't get me wrong, it's really important, but we need to do more to be able to be proactive in care versus always this reactive in care and have the patient come back every 3 months and it's exactly the same. And I have some of those too. Okay, and then again, when it comes to implants, we'll have different classifications to identify the health or the unhealthiness of the situation. And that's important, but I want us to dig deeper and really trying to understand so that we can focus on the less on the how and more and on the individual of the etiology or the cause, going back to that fever kind of explanation or analogy. So that then ties us into a classification system that allows us to do that. So we take our clinical parameters, we get a classification, and then from there we can really start diving into periodontal risk assessment, implant risk assessment, quality of life risk assessment. So assessments of the risk is really the key to try to understand what is the, I'll say in quotations, cause, which is not always easy to get and not to expect to have it on the first time you see a patient. It's a continuum of care. So leading this into the conversation of our AAP, it is quite overwhelming. So if you're there and you're struggling, it's okay. It's everybody. I still have periodontists who look at me and they're like, nope, not doing it. I'm like, what do you mean? It's not like you have a choice. So you're not alone in your struggles if you are indeed struggling with it. But this is my 4th time, that might age me here, on when I have had to have learned a classification system. So I hope I'm done. But I understand why they did the change, and it truly is a global approach, right? So you had the European Federation, the American, where's the Canadians? I don't know. They were lumped in there somewhere, and they had a conversation together so that we can really come to some kind of alignment and hopefully come to some kind of prevalence equivalence of what's out there. Because if you look at the research and you ask what is the prevalence of implantitis or mucositis, you have a range from 11% to 85%. That's not helpful for anybody. So now that we have a classification system, hopefully we'll have better epidemiological studies, which will give us better than understanding, and then hopefully have better care plans to support our implants, because it's no easy task for sure. Okay, so here in a nutshell is the 1999 classification system that we're all probably very used to seeing and utilizing. And here on the adjacent side is the 2018. Now there's even controversy, is it the 2017 or the 2018? I call it the 2018 classification system. There you go. I made an executive decision. Okay, so now you can see on 2018 that we have 4 main categories. Okay, and this is what we're going to have some conversations about, these 4 main categories, to be able to understand the generalness of this particular classification. So I forgot to turn my timer on, because when the Greek starts talking, even though she's been in private practice all day since 6:30 this morning, she can keep going and going. Okay, so the 4 main categories here, and then how does 1999 fall into the 2018 classification? So this is just an animation to kind of guide you through the new classification of periodontal health and gingival diseases and conditions. So that periodontal health and gingival health is new. We never had that before. So how wonderful it is to turn to a patient and say, you have gingival health and periodontal health. One day I'll be able to say that to my patients, but in a perio office, it's not as, it doesn't flow as easily. Okay, and then when we have the second main category, we have periodontitis. And in that classification system, now you start to see the changes that have happened. So we no longer classify chronic periodontitis or aggressive periodontitis. These are no longer the language that we utilize. We just say now it's periodontitis, but the disease has not changed. It's just the name has changed. So everything you've known about chronic periodontitis and aggressive periodontitis is still the same. It's just we've changed the name to reflect what we think chronic and aggressive no longer really define that individualism of perio. So that was the rationale behind that. And then we have the periodontitis as a manifestation of systemic diseases. So we already had that before in 1999. Everything that relates to that category is the same. So that's good. No big change there. Necrotizing periodontal diseases, that's now part of periodontal disease. And then when we go into periodontal manifestation of systemic diseases and developmental and acquired conditions, for the love of someone, do they have to be so wordy? Like, could you not have hyphenated that? Like, again, I was not invited. I would have changed the world if I had an opportunity to be present with them. But nevertheless, this is now the 3rd category, and the 3rd category really has thrown many people off. So we'll have a good chat about that later on. But in this category is where you're going to find abscesses of the periodontium, so perio, gingival abscesses, and then also endo-related lesions. You're going to find them in here. And then developmentals, things like traumatic occlusal forces, tooth-related factors, recession, all those are going to fall into this 3rd category. And then, of course, our famous new one is our peri-implant disease and conditions. So that's it, people. We're done. No, just kidding. It's these are the 4 main categories with their subcategories in them. But I do want to bring our attention to what actually is. Why is it always called a classification and versus calling the diagnosis? Because the classification is not a diagnosis. And this is where the challenge starts to happen, because we want to put people in the box. We're like, where does this person fit, to give them a diagnosis? But that's not what the classification is for. So it's a bit challenging, and that's why I think people get frustrated with it. But once you understand, you're like, oh, hold on a second. It's not trying to take this N of 1 and try to fit it into a classification. Then you start to go, okay, what is the best representation that I can classify this individual that best gives other clinicians the ideal of what's happening in this dentition today at this point in time? And I think if you take that approach, then you'll, maybe the frustration of trying to fit someone in a box is less. But however, so the difference between the two, now I'll put them both up, is when we are dealing with the classification, we are looking for like a full population of individuals. And we're looking to see how can we standardize these definitions that are intended to create this homogeneous cohort from the clinical research. So like epidemiological research, for example. So, and as it says down here, it says not to intend to capture the entire universe of possible patients. So you're not going to have every single potential variation of the patient in a classification system. So they're trying to give the general of where you fall into so that a patient also can understand, well, do I have health or I don't have health? And where do I not have health? Is it in my gums, in my gingival tissue, or is it in my attachment, in my bone? That is where the goal is for us as clinicians to utilize it to support a patient and their understanding. But it's nice also to have common language to be able to speak to different oral healthcare practitioners and specialists and medical doctors, for example, that we're kind of on the same lingo so that we can work collaboratively together. So that's the goal. But if you look at your standard practice and where it says, you know, that you have to create a dental hygiene diagnostic statement, it doesn't say you must use the 2018 AAP classification. It says you must identify where it is stability and where it is not in your realm of your scope of practice. So don't go away now because you're like, oh, I don't have to learn the AAP. But it's just to encourage you and empower you to say like, okay, you have time to try to digest this information. And it's not about being right, it's about getting it right. Okay, so you're learning to try to get to this level of understanding and then again, have communication with everybody. Okay, enough about that. So before we jump right into the classification, I think there's some important terms and concepts that we need to be aligned with. So what I'm saying and what you're thinking is kind of meshing together. So the first one is the difference between a sulcus and a pocket. And this is terminology from the proceedings, the European and the AAP, coming together to kind of explain their rationale as to why they did these classifications. So especially like if you have health, why is it 3 millimeters? So a sulcus or sulci, if you've got many, is of course 1 to 3 millimeters. And the concept is here is the ability for that environment, that microbiome environment, or that just the biofilm in that particular site on that tooth, if it's a 3 millimeters or less, is very different than when you have a closed pocket or potentially an active pocket when you have 4 millimeters and beyond. And that transition between 3 and 4 is where we might have, you know, the immune system reacting or the virulency of the biofilm, or particular species are now integrated into the biofilm, making it more virulent and dysbiotic, and then initiating a host response. So it's important for us to know that the language, and especially with our patients too, they can, you know, they start to understand this, but it's key to know the difference because the classification will rely on the understanding that if it says 3 millimeters, that is their interpretation. If they have a pocket, that's their interpretation. And that's why they distinguish it individually in the classifications. The next one is like, you're like, okay, Penny, I don't need to go back to school to learn how to probe. And no, you don't. But the classification system is, especially when you want to determine if you have periodontitis, is all dependent on your interdental, so in between the teeth, levels of bone. So bone loss, bone level, it's the words now are kind of interchanged. So your CAL, so your clinical attachment level or clinical attachment loss, now these two, they used to mean something and now they just like, look, we're just gonna, they're interchangeable. But it can be very confusing when you start interchanging them because for students and for clinicians, when you have healthy gingiva, you know, the sulcus is histologically at a maximum of 0.5 millimeter of depth. But when you use your periodontal probing, you're really not going to the base of there. You're usually measuring a 2 to 3 millimeters. So in other words, a sulcus. So if you have no recession, you know, this would result in a clinical attachment level calculation representing no loss of periodontal attachment. And so that then leads to, as you can understand, appreciate a bit of confusion. So you might hear me say true pocket measurements, or what is true CAL? so that we can have ensuring that we understand what we're kind of referencing. So to help with that, let's put some examples on here. Okay, so here's an example so that we have some reference. So we all know that our line of reference is the CEJ. And the reason why it's at the CEJ, because that is where the junctional epithelium will attach at about the CEJ. And so we use that as a reference to, in our clinical, when we're doing clinically with our probe, to get a sense of what is our level or loss of attachment. So in the first example in A, we're all going to agree it's a 4 millimeter pocket measurement. Okay, just work with me. And we're going to say, we notice now that the gingival margin is above that CEJ. So we have to reflect that to say, in this particular case, there is no attachment loss. And the measurement of 4, the probing measurement of 4, is not truly a concern. Oh, I have 4 millimeters, therefore I have periodontitis. No, you have to understand what the 4 means. So if you have a probe meeting of 4, but your gingival margin is above the CEJ, then in essence, you do not have a loss, okay? And the reason why we pick the CEJ is because it's a fixed point. However, it's not so easy sometimes to identify the CEJ, because you could have non-cervical carious lesions, or known as abfractions in the past, or chemical root erosion or restorative materials. And so determining the CEJ can be a little bit challenging, but what we're trying to do, like I said, is from that CEJ down to wherever the resistance, we'll just say, that is what we're trying to determine. And it can get confusing if that gingival margin is in different locations, like you're seeing it on the screen. Gingival margin is not a fixed point, so it can make it a little bit more challenging. So in the first example, you can see that, we have to address this. So in a lot of softwares now, they will do this. There'll be a plus or a minus to be able to truly reflect what is cal. In this case, of course, it would be 0 because there is no loss of attachment. And then the second one, in B, we start to see, okay, where we still have the gingival margin above the CEJ, but we also have measurement that surpass the CEJ. So in this particular case here, we have to subtract what we have above so that we can get a true cal measurement. And then as we keep going, this is the most common one, and everybody's happy with this because we can see the CEJ, we can see the gingival margin, and then we just add. So whatever our measurement, and add the difference of wherever the attachment has been lost, then we're able to get our cal. Okay, so I hope we're all good and we're ticking along, and there's no big question marks in the chat box. Okay, but this becomes really relevant when we start looking at the periodontitis and we start looking at staging. Okay, so keep this in your mind. Okay, and then new language, if you haven't heard it already, is the biological width has changed and has turned into supracrestal tissue attachment. Again, could you make it any longer? And it's just exactly is the biological width, but their rationale is biological width is a commonly used clinical term to describe the apical coronal variable dimension of the supracrestal attached tissues. So therefore, they said, okay, to be accurate, we should call it supracrestal tissue attachment, which of course is composed of the junctional epithelium and the supracrestal connective tissue attachment. Just sharing, don't shoot the messenger. Okay, so in keeping that in mind, when you have now your staging and you have to be able to determine if you actually do have periodontitis, so that'll be the conversation we will have in a couple of slides, but just now to kind of get your mind sort of hone in on, well, what does this interdental cal actually looking at? So we just did a clinical kind of setting where you would be measuring with your probe and doing all your annotation. And then now you're looking at if you do have periodontitis and now you're looking to classify it. You start looking at the interdental cal because you're trying to determine the severity. And when we have to determine the severity, the very first thing you need to do is look at interdental, so in between, and you have to go to the site that has the greatest loss. So you're like, okay, I get this, I get this. Then you start looking at your stages, which is, again, the language to align with other health professionals. And patients kind of understand this from medical sort of conditions. And then you start looking at 1 to 2 millimeters, 3 to 4, greater than 5. You're like, okay, this, kind of makes sense. But I'm going to bring your attention now to, let's say we'll go into stage 1, and we'll see like, okay, the maximum probing depth is, 4 or less, and we potentially might have some horizontal bone loss. So here is where the question, to make sure that you understand staging, how they would like you to look at it, is can you explain the fact that how is your pocket depth measurement greater than your cal measurement when we just said it's usually our plus or minus depending where that gingival margin is. So I wish you were all in front of me and we can, start seeing if people have the answers, or people are like, oh, I never even noticed that. So this is why I think it's key. And this is where, again, I've brought forward the things that most clinicians who I've chatted with or helped support them, this is where it has thrown them off. The true cal part, like taking the gingival margin and subtracting, is something they're like, what? I didn't even know you could do that, or you should do that. And then also this part here. So this is why. So when you look at a radiograph, so when you're doing your assessments, you may not always have radiographs available for you. So your first sort of knowledge that you're capturing, your data, is your clinical, what you're seeing and you're probing and you're writing down and you're annotating, which you must follow through with a radiograph to confirm whatever you're seeing clinically. Now, sometimes that's not always possible. You're in a long-term care facility, or you're in a community setting, or you're out in the, out in mobile. So this is not always the case. So that's why they recognize that at least if we have the knowledge of your interdental readings, we have a bit of a sense of what's happening. However, we know when it comes to probing, hygienists, unfortunately, are the worst culprits of overly putting pressure. The research will show 2 to 3 times more pressure, and therefore you have false positives, or you go through the junctional epithelium, and now you start having 10 millimeters all over the place. So really, in the sense of to confirm what we have clinically, the ideal approach is to have the radiographs to follow up. Now, when you look at your radiographs, you will see some anatomy, some key points. And the first one, of course, we want to identify is your CEJ. Then again, we talked about whether or not, where is that gingival margin in relationship to the CEJ? And so, of course, the gingival margin doesn't always show up on a radiograph. So this is where we have to take in that supracrestal tissue attachment zone, which is about, we'll just say 2 millimeters to help with calculations instead of like 1.193. And then we have to subtract that. So we can't include this area because the zone of 2 millimeters is not part of attachment loss. So when in reference to what the periodontitis staging is actually asking you. So let's go to an example. So here we have we'll say a moderate. So for those go back to thinking of chronic periodontitis and the moderate level, and then you will see the clinical attachment loss, 3 to 4 millimeters. That is what you will have on your periodontitis sheet for staging. So you're like, okay, but how do you get that when your pocket measurements and your cals are even larger? Well, this is why. So you take your distance from your alveolar crest to your CEJ. And so you measure it again at the greatest level of pathology. So you measure that. So you would take it, you try to find the crestal bone, and some computer systems now, softwares actually have rulers to help you do this measurement for you so that you don't have to estimate them. And then so you find your CEJ, and from your CEJ downward, that would be 5 to 6 millimeters. So then you would subtract the 2 millimeters of that supracrustal tissue attachment, and that is how you get to 3 to 4 millimeters, and that would then put you in that zone of stage 2 in the new periodontitis staging. Okay, so if we look at another one, so this is where we would have, again, your interdental cal, so in between the teeth is the measurement, not your recession buccal or lingual, only interdental. And then if we go on to, greater or equal to 5 millimeters of cal, this is what this might look like on a radiograph when we have more severe advancement. So again, you'd be going from your CEJ down to the alveolar. What would be that measurement? So here it'd be more than 7. You would still subtract that 2 millimeters, and then that's how you would get the value of your true clinical attachment loss confirmed on a radiograph. Okay, I hope that was good. All right, so when you look at these two cases here, you might not be sure by just looking at it from a clinical perspective, yet again, why we want to have our radiographs, to say which one is periodontitis classification. So to help us to try to do that, of course, we need some clinical parameters in radiographs, but just off the bat, again, it reinforces the fact that they have come with this, the endpoint being they have attachment loss. But however, how they got the attachment loss might be different, and therefore their classification might also be different. And it's not just periodontitis because you have attachment loss. And the two important things that need to be considered to make a classification, you have to separate the gingival health and you have to separate the attachment. So it's bone along the tooth surface or bone, of course, along an implant surface. You have to know both on either side to be able to come up with one classification. So in the past, in 1999, if we said moderate chronic periodontitis, it was assumed that the gingival tissue was inflamed. And now we're teasing it out so that we can best represent what we have. Okay, so that's the rationale. Okay, so back to our, now we're giving you a good sense of what's to come and how we're actually now going to classify in these 4 main categories. So the first one we talked about was periodontal health. Okay, so this is a decision tree, logarithm, whatever you want to call it, a help support system, a resource. But this helped me when I would start learning it. And then I've shared it with others and they felt it helped them. So I'm hoping it's going to help you as well, to help you navigate how do I fit this into the 4 different categories. And if we had more time, then I can teach you how you can go into the subcategories. So, but the first one is really important because, again, we don't want to overdiagnose disease. We don't want to say, everybody has periodontitis. Right? When we get those epidemiological, right, and like especially if you look at North America and like more than 50% have periodontal concerns, well, we want to know, is that really accurate now? Because we have a classification of periodontal health and gingival health that we didn't have in the past. Did we lump everyone together? Okay, so the first thing you want to ask yourself, the question is, do I have interdental cal, either from the clinical, when you're doing it, looking inside the patient's mouth, or you have support with your radiographs to see where are you at. So if you don't have interdental cal anywhere, I'm not talking buccal or lingual recession, interdental, if you don't, then you're on the line of having health. Now, we don't know, is it gingival health only? Is it attachment levels health only? We have to now kind of distinguish between those two. So if you walk yourself through, then you say, okay, I don't have interdental cal, so I'm leaning towards I might have healthy tissues and I might have healthy attachment levels. If I have clinical parameters that are telling me that I have inflammation via bleeding on probing, then I need to fall into different camps. So if I don't have interdental cal, I do not have bleeding on probing or less than 10% in the full dentition, then I'm going to fall into the classification of periodontal health and gingival health because I don't have the attachment and loss or levels that are, right? I have pristine or an intact periodontium. However, if I have inflammation in the dentition more than 10%, and usually we identify bleeding or probing as our cue as a clinical to see whether or not we have inflammation. When we use the right forces in our probing, then you would potentially then have gingival diseases, or potentially you have just gingivitis, but you still don't have a loss in your periodontium. And that's what the first category, remember there's 4 main categories. So the first category, this is what we are referencing. So you're in here, and now you have these subcategories that can support you. So this is what it potentially might look like. So you have periodontal health and gingival health as the category. Now you're trying to understand the periodontium. Do I have pristine? In my world, pristine periodontium is a unicorn because in perio, it's rare. And then, but I can have potentially intact periodontium on the rare occasion, or I will have loss of, or a reduced periodontium. But in this category here for our conversation right now, this is how you would classify to say gingival health on a pristine periodontium. These are the language, pristine, intact, reduced. This is the language that is in the classification. Or you could have gingival health on an intact periodontium. Okay, so this, like I said, this here is a unicorn for me, but you might have many of these in your practice. So hopefully you're classifying them, the deserving classification. Now, the difference you're going to see here between these two is you'll see the terminology, gingivitis or gingival diseases that are non-biofilm induced. So gingivitis, it truly speaks to the just containing to the gingival tissue, and the gingival tissue is inflamed, or it has some kind of identification that it's not biologically compatible. And therefore, and the main reasons are biofilm is initiating or exacerbating the condition. And when you talk about gingival diseases of non-biofilm induced, these are things that are tied into perhaps like lichen planus, things that no matter how much non-surgical debridement, oral self-care will not change the outcomes of these. And so that's a nice way to be able to distinguish. They, again, might look their end result. They'll have gingival, perhaps inflammation, edematous, red, fiery red tissues, but they're not the same etiology and they're not the same treatment. You can potentially debride to your as happy and content, and it will not change the gingival tissue if it's lichen planus. Something else may have to go into effect to change that outcome. And that's why it's so important for you to ask the why, so that you can fall into the right classification, so that you can employ the right care plan to get the best results and outcomes for your patients. Okay, so here are some examples that we already know when it comes to gingivitis and that are biofilm induced. These all fall into this category here. So drug influence, hard to speak with my trays on. I should have took them out. However, if I took out my maxillary retainer, my 1-1 temp would come out, and it would be, I'm almost tempted. I might do it at the end. It is so funny. It's amazing how teeth and hair and all that really changes someone. But if I took my retainer out, my 1-1 temp would fall out. And that's all you would be able to think about. So that's why they're in. Okay, and so serious business here. We're talking about the AAP. So these 3 main categories all fall into gingivitis biofilm induced. So we don't need to go into further details. I'm still thinking about my tooth. Okay, and then gingival diseases. So you see how it's not called gingivitis, it's gingival diseases or conditions, and these are non-biofilm induced. And you can see that there's an array of reasons why it could fall into this category. And then again, you'd want to be able to classify them appropriately. So these are just some examples of, let's say you have an intact periodontium, or a pristine, right? Because even individuals who have no attachment loss could have a gingival disease that's non-biofilm, lack of nutrition, cancer, an allergic reaction, things like that. So those are some examples. And this is how you would actually do the annotation in your underneath your dental hygiene diagnostic statement. But everyone is doing. It doesn't just include the AAP. It should have a whole paragraph about social determinants of health and their SMART goals and their oral self-care and so on and so on. But we're spending our time on the AAP tonight. Okay, so back to our worksheet or workflow or algorithm to see how do we progress further. Okay, so we just kind of recap to say if we have health, we have our pristine or our intact periodontium, and if we have bleeding or clinical inflammation, yes, no. If we do, we have more than 10% of that dentition, then what do we call it? Is it biofilm induced or non-biofilm induced, or right, is it a gingival disease? Okay, so in our last slide, I had said potentially it could be a reduced periodontium. So in 1999, we didn't have this language of reduced periodontium anywhere in the classification. It is something that clinicians brought into, we just broke the rules and we said we need something to identify that we had a history of attachment loss, but the patient is stable right now. So we don't feel it's appropriate to keep calling it chronic periodontitis. So we use the term reduced periodontium. So in the new or in the current classification, listen to me, they included the reduced periodontium. And so this is how now you can utilize that language to help you understand if your patient indeed falls into this classification and not necessarily under periodontitis. So if you have in the first main category, right, periodontal health and gingival health, you could have a reduced periodontium, which simply means, as it shows in the picture, that the bone level or the alveolar, the crest has moved away from that connective tissues on, from that 2 millimeter from the CEJ and has moved apically. So this particular case here shows that this patient was someone who previously had periodontitis, and we did initial therapy, and we are all wonderful, amazing clinicians, and we got all the 9s and 10 millimeters back to 3 millimeter sulci. Yay us. Now, however, there are other conditions in the dentition that might present themselves to you that also look like you have attachment loss. Because if this is a new patient to you, how are you supposed to differentiate between the first one and the second one? Because again, in the end, they have the same results. The end is they have attachment loss. However, one had it from true perial pathology, pathogenesis, and the other one had crown lengthening. Nothing to do with perio, never had perio, had just a broken tooth. And because we needed to get access, we had to remove the bone around to be able to have this crown fit appropriately. So again, going back to the why, now sometimes patients are the worst historians. They don't even know they have implants in their mouths. When did you have an implant? Oh, I think I was in Alberta. I don't know. Where is it? I think it's here, or maybe it's here. So it's not easy to get this information, I understand. But it's important for us to understand that we're not classifying disease when it's not actually there, right? So the classification of periodontitis would be inappropriate in this reduced periodontium that is non-periodontitis. So the language of the AAP and the EFP is they refer to this as non-periodontitis stability. This isn't progressing any further. It was due to a surgical procedure, has nothing to do with pathogenesis. And the top one, though, very much like the language that we would use with cancer patients, they're in remission right now, they're holding steady, and then anything can change. We can go back into perio because we know that periodontal disease is episodic. It's hard to do with my left hand. I can do much of it. Okay, the girl's losing it a little bit. All right, and so now we keep going further. So if we have a reduced periodontium, we have to now start asking ourselves, okay, do we have health around it or not? So when we walk ourselves down the flow chart, we say, okay, do I have interdental cal? Yes or no? Okay, yes, I do, because now you have reduced periodontium. And now, what are my measurements? Am I in a 3 mm sulci, or am I in 4 mm pockets? What am I dealing with? And then as you walk again yourself down, do I have clinical signs of inflammation or progression of disease? Then I have to answer yes or no. Okay, so let's walk us through. So I have interdental cal. So let's use these examples on the page here. So here I have, again, I'm still in the first main category, periodontal health and gingival health. I have a reduced periodontium, which is telling me that I have a history. In these two cases, I will tell you, because I'm a good patient, that there was a history of periodontal manifestation, and we did initial therapy, we had great resolution, and now we have our measurements, and we have potentially our gingival tissue, as you're seeing here, are healthy. Yet we cannot forget the fact that this individual can go back into activeness in their periodontal pathology. And so we have to be watching and monitoring very closely. But right now, at this current moment, they have gingival health. So they have pocket measurements that are reflective, and they don't have clinical signs of more than 10% of their dentition to actually be of concern at this point in time. So we can say in this particular case up here that it's gingival health on a reduced periodontium. And you can even classify the reduced periodontium to identify, do I have slight, moderate, or severe? So you can go even further, again, to really represent what the patient clinically is showing. So if another clinician was to just read your dental hygiene diagnostic statement, they would know exactly what they're going to be looking when they see the patient, if they were to follow after you. And now if for some reason you have these 3 mm sulci in a reduced periodontium from someone who previously had periodontitis, and they have more than 10% that bleeding on probing, you can say, in this case, it's just the gingival tissue that is inflamed or reactive or progressing, but not the attachment level. So in this case, you can say gingivitis on a reduced periodontium. Okay, now some of you might be now putting question marks in and saying, wait a minute, you said 3 mm, you have 4 here, Penny, you made a mistake. So here's the next slide to help navigate this conversation. Okay, so when we have individuals who were classification of periodontitis, those of you who work in this realm know how challenging it is to get someone to go to a 3 mm sulci or even one sulcus. So both the organizations agreed that if someone had a history and now their gingival tissues are healthy, there are no signs of clinical inflammation or more than 10%, and their readings are 4 mm, we will accept for these people, these special people, we can still call them health. So you can still say gingival health on a reduced periodontium. But if you have now a patient who has a reduced periodontium and the measurement of a 3 mm sulci, but you have bleeding on probing at that 3 mm mark, and you have more of that 10% of those 3 mm readings. So you have 3 mm readings and they have bleeding on probing and you've got more than 10%. Now this is how you classify gingivitis on a reduced periodontium, because they start to recognize how difficult it is to have them go way down to 3 mm sulci reading. So they accept 4 mm, but no bleeding on probing. You cannot have a 4 or equal to and have any bleeding on probing at that 4 mm. As soon as that starts to happen, then we have to be very consider it that potentially we have active perio, and then they might shift out of this gingival health, or they might shift out of the attachment levels being stable. And then, of course, this brings us into that conversation now about what happens when we have a 4 millimeter in a reduced periodontium and a 3 millimeter periodontium. So I am going to pause here. And this is where I'm like curious to see, are we following along? Have I lost anybody? Our confidence level is improving. We're happy. Any questions that well, obviously I can't see any questions, but.
Here, and I love. That's just great. I have some questions for you, and no mine's my echo.
It's less of an echo. It cuts out, so we
can't
hear.
Really? Okay.
Well, for me, anyways. For me.
All right. Question. Somebody asked, you said active versus closed pocket. I'm not familiar with these terms.
Okay, so let me go back to here. So if you go to the article, Chappelle's article in if you go to perio.org and you go member services and the proceedings, those articles there, that's where this article is. And so this is their language. So they consider that when you have a 4 millimeter measurement of pocket measurement, then they consider that no longer a sulci, of course, and they consider that a closed pocket, where now you have this ability for it to be active in the progression of disease.
Okay.
I hope that helps.
I have asking if you get any of slides.
Yeah, so I sent them in. So I
didn't get any.
Oh.
Yeah, I didn't get them. Sorry. I can get them to everyone. Don't stress about it right now.
Okay.
If you email them to me.
I did.
Tomorrow.
I did email them just before the session because I was concerned that I wasn't going to be able to upload them, in the chat. It didn't come through. Okay.
That's okay. That's okay.
Sorry, guys.
I will get it, everyone. Don't worry, everyone.
Okay.
We'll get them, okay? And I think there was one more. Yeah. I think somebody wanted to know if they could get a quick education on the difference between a sulcus and a pocket. So kind of the same.
Kind of the same thing. Yeah. So when we reference the sulcus in the language, it's 3 millimeters or less. And when we say pocket, we're always referencing 4 millimeters and above.
Yeah. Great. I think that's it for now.
Okay. Good.
Any other questions? I know. Sorry guys for the echo. Go ahead, Betty.
Okay. Thank you. Okay. So now this leads us into the conversation of going down through our worksheet here. If we have interdental cal, yes, we do. Do I have 3 millimeter sulci, or one is sulcus and multiple is sulci? And I put the asterisks here to kind of just jog the memory that if it's someone who has had a history of periodontal disease, then we accept 4 millimeters with no bleeding on probing at any of those 4 millimeters as gingival health on a reduced periodontium. Now, remember those people who had the crown lengthening, right? So they didn't have periodontal disease. So they don't fall into the same, we're not as concerned about them because they didn't have perio in the first place. So they could have, it's not as concerning. So this is where it kind of walks you down here to make sure, what do I have? And that's why it's always important to ask the why question so that you can classify the individual person that's in your chair at that point in time. What do we have, right? Because obviously, like I said, perio can come out of nowhere. And a little stress can cause a lot of perio. Okay, so now if we have 4 millimeter pockets, now this is sort of our trigger to make sure to say, okay, the first question is, I have interdental cal. So that means that this 4 millimeters, I want to make sure that it's a, it's obviously you've measured it. So it's definitely a true 4 millimeters. But what does it mean? Where is that gingival margin in relationship, right? But because we have interdental cal loss, we just still want to make sure, because you can have interdental cal, but the gingival margin is still above the CEJ, especially if you've got, lots of inflammation or you're a drug that's influencing the gingival margin, because the gingival margin is never a fixed point like your CEJ is. So just always be mindful. I have a 4, but what does it mean? So, okay, do I have interdental cal and I have a 4 millimeter? Okay, now I have to start paying attention, because now we could potentially be in active disease phase. And then that brings us into the classification of the second main category, which is periodontitis. So in the past, we had moderate, light, chronic periodontitis. So we don't have that language anymore. There is no moderate periodontitis. It's just periodontitis. We don't have aggressive anymore either. It's simply the category of periodontitis. Why would they have the main category and then have a subcategory? I do not know. It plagues me. Nevertheless, these are the main 3 subcategories of periodontitis, the second category in the 4 major categories of the current classification. Okay, so like I said earlier, the periodontitis as a manifestation is exactly the same what it was in 1999. So these are the severe, unique, rare diseases that can influence Down syndrome, Papillon-Lefebvre, what else can I think of? Neutrophil deficiencies, all the very complex systemic that has an impact on the aggressiveness or the change in perio is what that classification is. It is not diabetes unless it's quite severe, like it's uncontrolled, but no. So cardiovascular disease, diabetes, these do not fall into this category, nor did it do in 1999, but there's a bit of a confusion there that for the most part, sometimes with individuals trying to identify between this category and this category that has the manifestation of systemic diseases, because they have the same language. Systemic diseases, systemic diseases. We can understand why it's confusing. Okay, so now to try to really understand, do I truly have periodontitis? So there's a few criteria that you need to ask yourself to make sure, does it actually qualify? So our very first one, we know already, we've been speaking a lot about it, is that interdental cal. But what's important now is to go, okay, what if I have the distals of 7 and I have an 8? Does that count? So the answer is no. So 8s are traditionally not considered in the qualification of the diagnosis. Neither do distals of 7, because many times the 8s maybe have impacted the distals of 7. And again, extracting an 8 has nothing to do with periodontal disease. It is a representation of a manifestation that happened that looks like periodontal disease because we have attachment loss, but has no true periodontal pathology. So that's how you distinguish, and that's why 8s and distals of 7s are not used to quantify or maybe qualify for the classification of periodontitis. So, however, once you go through this qualifying for periodontitis, and you have 8s and distals of 7s do have periodontal potential representation, then you can include them in the overall to determine how much disease do I have in the mouth. Okay, so the very first thing that you do is you have to ask, do I actually have periodontitis? Then you will question, how much do I have later on when you do your staging? Okay, so we talked about interdental cal. Do I have it? Okay, all right. Your pocket measurements of your determining when you take your probe and what do you have a 4 millimeter pocket measurement. That's important to know because we had that discussion between 3 and 4 millimeters. The next thing that you need to know is like, okay, where in the location do I have this interdental and pocket measurements of 4? I have to have at least 2 sites 2 interdental or more. You can have more, of course, but you must have at least 2 that interdental sites, so like the teeth, in between the teeth, that are, and also that are not adjacent to one another. So you have to have them in different locations so that they're not just side by side, and there could be an issue of you know, a roof fracture that happened in between the 6 and the 7. So that would not necessarily be periodontitis. That could possibly be a periodontal manifestation of, because it looks like perio, and or we don't know what's caused it, and we suspect there could be a root fracture, but we're not 100% sure. But it's not true periopathology, so we don't get confused with the classification. So this is how we would support. And then there's one more that I'm going to keep hidden. It's a secret. No, it's not. It's just to help with the flow of understanding. And then we will go into the last one, because it's a different scenario. Okay, so here's an example of, okay, this is old school odontogram. Do you miss the old school odontogram? I do. Okay, so here's old school. So, you know, just to follow us through, you have your pocket measurement, your recession, and your mobility. That's just all. And then, of course, these squiggly signs here are furcations along the way. But it's, and then the lines on top are the to identify bleeding. So reminiscing of old times. And okay, so if you look at this example now, does it meet the first criteria? Absolutely. Do I have pocket depths that are equal or greater than 4? Yes, I do. And I have at least 2 interdental sites or more that are on 2 or equal to non-adjacent teeth. Okay, so we can now say, yeah, absolutely, this is periodontitis. So now the other case, or the other box that I had left closed, is this scenario. So when we have, how can I say, sort of, I want to say buccal and lingual, and perhaps maybe non-interdental, potentially we can classify this as periodontitis. So these cases are rare. I mean, it took me forever to hunt to try to find someone who had something close to this classification. So the or there is like, so the first 3 that we talked about. So if they don't have the first 3, but they have this kind of representation, then this also could be referenced as periodontitis when the facial and the lingual are, and here's another brilliant idea. I don't know what to call it, but it's frustrating as heck. So instead of saying buccal, they call it oral. Like, what? Like, okay, enough about that, because I can go on and on. So I'm going to keep saying buccal or facials just for us, but know that if you read the literature, it took me like 3 reads to go, what are they talking about? Why are they? So there you go. So if you have it between the buccal and the lingual, and you have your measurements of your cal are greater or equal to 3 millimeters, and your pocket depth measurements are greater than 4 millimeters on at least 2 or more teeth, then you can also classify it. But these buccal, lingual, or facial or lingual, you also have to be able to identify that there is no etiology to that. So it's not something like you had gingival recession from traumatic origin, or dental caries extending in the cervical area of the tooth, or endodontic lesions draining through the marginal periodontium. So, or of course, a vertical root fracture. So these would not quantify to be periodontitis if you had these representations. Okay, but this is rare. All right, so don't get too concerned about it. And I think I'm getting tongue-tied, and I think I might have misspoke. So I was just reading here, buccal or oral, and I might have said buccal was oral. I should have said oral was lingual or palatal, because they didn't want to have 2 separate, lingual, palatal, so they called it oral. So I might have said buccal. Correct me if I'm wrong. All right, so now that we have the classification of periodontitis, now we can say, okay, how do we stage it and how do we grade it? And this is, again, where it comes a bit more perplexed. Can you tell me what time we finish at, or in my time? I don't know what time zone. So in Penny's time zone in Vancouver, I go to what time?
Yeah, so you got another 45 minutes.
45 minutes. Okay. Okay, good. Okay. Excellent. Okay, so now we're at this, we confirm we have periodontitis, now we have to stage and grade. And so what the heck is that all about? So if we go back to now so like I said, this is where you can go to the perio.org or the European one and download these resources and laminate them and help yourself and guide your way, make notes on it or whatever. Okay, so when you have your stage 1, stage 2, and you have your stage 3, stage 4, this is where you take the stage 1, stage 2, and you take the 1999 and all the classifications that you would have, your clinical parameters that would have brought you to mild to moderate. This is the camp that you will probably fit into to transition you to say it's probably stage 1, stage 2. If you had the classifications of kind of that moderate, but more leaning towards advanced, like you used to say moderate/advanced, because you're like, so anything that had the potential to really get further into that pathology or really severe cases, then it's going to be stage 3 and stage 4. So that kind of helps you to divide the staging because you know the classification from 99. And so now you kind of know that language. And you're like, okay, now I can see which camp I fall into. However, this is really important that you don't remember this is a classification system. So if you're trying to put someone into a box, you're going to get very frustrated. So always think in the back of your mind, okay, I'm going to take the area of most pathology, and of the most pathology, now which one represents the best, the language here that's going to support this person, and then of course the care plan that comes thereafter. So stage 1, most people don't have issues with. Stage 4, people don't have issues with because it's quite severe. This is stage 4. It's where you need to do rehabilitation in the mouth to get it back into function. So, you know, you've lost a lot of teeth. You have the potential to lose the full dentition. And so that's kind of like, okay, I got that. And then I got stage 1 because it's the earlier onset. Stage 2 and stage 3, everybody goes, which one is it? So let me help you in let me just help you. I hope I'm helping you. All right. So when we get to the severity, how can we look at things that are going to give us right off the bat that clinical support and saying, is it stage 2 or is it stage 3? So we already talked about the fact that we have interdental cal, right? Is kind of like our number one thing, because a lot of times we don't have radiographs. We just have our clinical notes that we have, because depending on the setting that we have. So your interdental cal, your first line here is going to be the most information that's going to give you what stage is going to be. Then to support you, we know we need the radiographs, but we don't always have the radiographs. But if you're lucky to have the radiographs, then we're going to look at that for understanding the severity and, of course, tooth loss. Then we need to understand the complexity. So what do we have in there? So like I said, stage 4 was we needed rehabilitation. That's a complex case. And then, of course, the extent. How much of the disease do I have? Is it generalized in more than 30%? Or is it localized and I just have less than 30%? I'll tell you my thoughts on that. I don't like this language. I always want to quantify. There is a huge difference between 0 and 30 and 31 to 100. So I want to know that extent and distribution along the way. I feel we should quantify more, but that's my own issues. Okay, so if we look at severity here, this is, like I said, our primary goal is to classify the severity and the extent of destroyed and damaged tissue caused by true periopathology. So we measure our cal we talked about, and how else can we support in understanding the severity? We look at our radiograph bone loss, we will in just a second, and then determine if any teeth are lost to periodontal disease. Now, this is always a challenging one. So I'm just going to hold off on that, and we're going to walk us through these severity sort of these three main categories. Okay, so we talked enough about CAL, so we're going to just jump into radiographic bone loss. And so if you have your radiographs, then you can use this ladder approach, and you just divide the radiograph into thirds. And so being mindful that you're going to give that space for that 2 millimeter from your CEJ, where you're not going to consider the bone loss in there, because that is what you are looking for. That's the space that we reserve. And we look from the alveolar crest up to the CEJ, right? So track the 2 millimeters-ish. So that's why the ladder is kind of helpful to decide, and especially when we talk about the language. Is it coronal third? Is it extending to the middle? So these are just easy things that we can do. A lot of softwares do it as well, so that's also an option. And so when we now start talking about the teeth, okay, so if we have individuals who come to us and they have teeth that are missing, it is quite challenging for the patient, who are not great historians, and ourselves to identify whether or not was this lost by perio, was it lost by a fracture, did you have an endo and it broke? Like, it's hard to know. So my guide for you is, if there's periodontal disease identified in the current dentition, I kind of make the assumption that potentially these teeth might have been lost. But in my statement, in my dental hygiene diagnostic statement, I say, you know, this is the baseline, based on the knowledge as much as I know, based on having radiographs or need to wait for radiographs to confirm, or radiographs are coming from somewhere else. This is the best, you know, classification I can give to be able to start from somewhere. Now, if you do have teeth though that are present and they have been classified as hopeless, then they are part of the teeth to be lost. So even though they're still in the dentition, but they have been given the prognosis of hopeless, they are also to count towards that teeth are missing, even though they're still in the dentition. Okay, so hopefully that clarifies a little bit about the tooth loss due to periodontal disease, which we don't always know. Okay, and then when we jump in now into complexity, here is where we're trying to figure out what level is going to support the management. I don't like the word treat, as you can tell. I always try to avoid it because I don't think we treat anything, but how can we manage this case? So the more advanced in the furcation or mobility or ridge defects, so how much is that going to impact the complexity? And complexity is the secondary goal, right? So severity is the first, and complexity helps guide and navigate where, okay, again, do I have, vertical bone loss, for example? So if you have vertical bone loss, then you know you're going to be most likely in stage 3, because the complexity of being able to change that trajectory is way more challenging than if you have horizontal bone loss. Okay, so that's kind of how you navigate the making the decision of that complexity, and that can help you to sway for you to make that decision. Is it stage 2 or stage 3? Because you can see in stage 3 we have furcations. So if you have a class 2 or class 3 furcation, by all means, that is always more complex in managing. So in my opinion, it would go into stage 3, even though perhaps maybe there might not be as many tooth loss or no tooth loss. So I hope you're starting to appreciate that this isn't just like everything has to be in stage 1, that's it. And then everything has to be in stage, because that's not the reality of our dentitions. So you're going to use your first goal to help guide you on where you're at, but then you're going to kind of confirm it with the level of complexity. How complex it is for this to restore it back to its biological compatibility. If it's more complex, then put it into the higher stage. All right. And then our last thing that we have is the extension. So this is straightforward. This is not changed from 1999. So how much do you have in the dentition? So like I said, I would like to quantify if it's 5%, 10%, but in the language, you can say localize if it's less than 30. and more if it's generalized, if it's more than 30% of the site. So the tooth, not the measurements, not the measurements that you take, but the tooth itself. So based on the tooth, what is the extent? How many teeth do you have? Is it localized to just the molars, for example? All right, and here just as an example for some of you who may not have seen a molar incisor pattern, this is what it would look like. And so again, this is to capture individuals who traditionally present themselves with aggressive, as we would know it in 1999, is their pattern that is most common, but it's not always. We have seen aggressive cases that don't have the molar incisor pattern. And and it's very sad because it's always the nicest people who have severe disease and you're just like, oh, what can we do to change this? Okay, so that was easy peasy. All right, on to grading. So now you've staged it. And so now you have to grade it. And what the heck is grading? Well, grading just simply means you're trying to be predictive. You're trying to understand what is the rate of progression? How fast can this go, this periodontal disease? Do I have it slow moving? So the risk assessment of your progression, is it slow, is it moderate, or is it rapid? And that is what all grading is about. So the nice thing about it, when we learned how to do this, was the one of the individuals, just I've lost his name. He's like a guru. How could I forget his name? He came to the AAP. I can describe him. I have the noun disease. Like I can describe him. I can tell you what he was wearing that day. And he was at the AAP, and it was the one that was in Vancouver, which is unusual because it's an American. And it was at the convention center. And he's a, oh my goodness, pain. Okay. Oh, it'll come to me. So he said to us, put everybody as a default to grade B, and then try to justify whether or not it would move to A or C. So that's great advice because the majority of the people fall into grade B. But that's just, you make that kind of support decision, and then you really have to confirm it. You don't just put grade B just because the person who said it at the AAP said you had to put grade B. But it's a great support so that it helps you. And other things that are going to help you now is using which parameter is going to be supportive. So your primary criteria that you want to utilize whenever possible is that direct evidence, and that is radiographs. So we know how easy that is. So if you have your radiographs and you've had them for 5 years, then you're golden. You're good. However, if you don't have radiographs, it's a new patient, or you haven't, whatever the situation might be, then you would use indirect evidence, as you see on the screen here. And that is where you use a combination, again, of trying not necessarily to fit someone in a box, but to see, okay, which one best represents the situation as it is right now currently. So if you take the percentage of bone loss, so if you go back to the thirds, then you can say the percentage there, and then you divide it by the person's age. So that helps you to determine, right? So if you have someone who's 65 and they have, a moderate, they're kind of like in the middle or close to the apical third, then you know that it's probably a moderate rate and there's nothing else that's of concern. But if you had someone who has that same percentage, like in the middle, the radiograph bone levels are in the middle of the root, and the individual is 20 years old, now you know that you're going to be in grade C because the rate is quite exponential, and you also may not have evidence to support that you don't have a significant amount of quality and quantity in the biofilm to kind of explain why we have such destruction. Even let's say their oral self-care is immaculate, right? So this again ties into capturing individuals who have that aggressive level of progression. Okay, so now to bring to your attention, the last part here is grade modifiers. So we can have a really good debate on smoking, and I'm not keen on how they put this into the grading, but I can work with it. So I don't think we need to go too much into details. It's a pretty straight, explanatory from the details that they have. And then again, diabetes, we have a lot of evidence, so I'm very grateful that it's there. And then of course, if your A1Cs, depending on where they fall, then that helps support you to be able to determine in combination, right? So your primaries, your direct evidence, if you have the radiograph and you're seeing this over the 5 years, then that is going to determine your grade. However, if you don't have that, or something changes within the 5 years, so maybe within the 5 years, something, it kind of hovered maybe around here, but now they've just been diagnosed as a diabetes, or they started smoking, then it's going to shift them over. Right? So again, not trying to fit them into a box, trying to find the appropriate predictive of risk of progression, kind of like Carrie's risk assessment, low, moderate, high. Which one do they fill into the best? And therefore, what plan are you going to do to address low carries or high carries? Same thing. How are you going to address someone who's at a grade B or a grade C? Now, when you go to the article, what you're going to do on a Friday night with a bottle of wine, you're going to go to the journals and you're going to read them like I had to, and you're going to see that the article itself has the same table as they do on the resources, but you're going to see it continues on. So it doesn't just say stop at grade modifiers of diabetes. It keeps going. So the risk of systemic impact of periodontitis. So the risk of systemic impact. Yes, I've said it again, because now we're finally having language that is trying to determine, yes, we can say causation. Yes, we can say bidirectional. Yes, we can. Right? We're still fighting about that, but we know that the link is most definitely inflammation. So what is that inflammatory burden? We're starting to have some data that's being populated based on the evidence and research and clinical expertise, but we're not quite there yet to be able to have it determined for sure. So stay tuned. Or you can now start using it and working with the medical doctors to actually see, can we have this test done if you're really concerned about a patient? But again, the healthcare system is a bit challenging, but nevertheless, it's on there. And the next one is biomarkers. So we have indicators of CAL, bone loss, so saliva, gingival, correctly fluid serum. So there's question marks here because, again, the evidence and the clinical expertise, we're just not quite there yet. But I wanted to bring it to your attention because we need to stay alert to this. And I don't think it's too far-fetched in the next 5 years that we have, we take the saliva sample and it helps guide us as a screening tool. Just like when we take blood pressure measurements, we don't say, you have high blood pressure. We say, right now, this measurement seems out of the norm for your measurements, and maybe we need to investigate this further, right? Sometimes we take 3 measurements, we make sure the patient calms down, and they're screening. So same thing, saliva may not be diagnostic per se, but it's definitely going to help us, and especially in our omics, genomics, epigenetics. If you have a chance to get into some kind of business that does the omics, get on it, because it's going to be big in the next 5 years, 10 for sure. Okay, enough about that. All right. So now we're on to the third category, and I am mindful of the time. And so the biggest takeaway for the third category, I think we've already kind of touched base on it, but when you are in the periodontal manifestation of systemic diseases and developmental and acquired conditions, again, a mouthful, start thinking about things that are affecting, and don't get confused or try to not tie in what we talked about in periodontitis, that systemic manifestation. I wish they would have used different language, but really what they're trying to say is, what is the why? So you have attachment loss, you have to dig deeper. Is it because of perial pathology? Is there a systemic disease that is potentially influencing it? Or is it something like, you know, all the other inflammatory chronic diseases, are they influencing the gingival, the periodontium? Do you have recession? Do you have traumatic occlusal forces? Or you have a crown margin that's impinging on the supracrestal attachment tissues? Those kinds of things need to be separated and teased out. Sorry, I hit the cursor too soon. So this is that third category that has all of this, and you can have multiple classification systems. It doesn't have to be just one, right? You're going to need more. If you have implants, you're going to have implant classification, the gingival tissue, the attachment. So there's more than one is okay to have, because again, you're trying to represent clinically the best description of that patient in front of you. All right, so here are some examples of documentation. So the most important takeaway when it comes to staging, there's only one stage and one grade for one patient. Your staging traditionally never changes. Just like cancer, if you were diagnosed with stage 4 cancer, you might be in remission, you might be cancer-free, but you'll never lose that stage 4 because it can always come back. Same thing, that's how they view perio. However, your grading can shift. So if they're no longer taking meds, or their A1Cs get improved, or they stop smoking, or other things, then the grade can change depending on the information that you receive. That risk assessment, right? If you had high risk caries, and you created a plan and other things change, maybe they got off a medication and now they're at a lower risk, then your care plan is going to change to address that as well. Okay, I'm sure that we are feeling so confident right now. So I'm going to just keep going. All right, so this brings us to our last classification system, which is peri-implant disease and conditions. And it has 4 subcategories to it. We're just going to focus on these 3 because of the time that we have, and help support you in navigating how do you maintain these implants that are at these different levels of disease. Okay, so the first important thing that you have to do is understand the components that you are working with. So if you look at a radiograph up here and you're like, I don't know if that's a tissue level or a bone level implant, I don't know if it's screw retain or cement retain, you really do have to push yourself and asks for support. So if you do, fantastic, thank you. And sometimes it's not always easy to identify. There are over 800 implant companies, and with international travel, someone lives in Italy and gets an implant there, they come to Canada and they decide to live here, and then it's like, there could be an implant system that you can't recognize. So that's for sure. However, most clinicians who place implants use no more than 3 systems at a time because it's so darn expensive, all the components and the parts. So it's easier for you to get accustomed to knowing the implant systems. And it's important that you do, because you want to be able to identify, do I have gaps between the collar and the pros? What's the abutment? What's the screw? Does it look like it potentially is tilted? Is it cracked? Okay, so the more you look at these things, the more you'll be able to identify issues, but you got to know what you're looking at first. So when we say bone level, I don't really like bone level because bone never looks like this. But what they're trying to say is the color of the implant is flush-ish, because bone is never straight. It's like a Pringle. So it has a saddle, and it goes saddle one way and saddle the other way. So that's just to give you the visual. But what they're trying to say is you can tell the difference between the top of the collar here versus here. And again, it's important for you to be able to identify that. And so when you look at this radiograph here, this is where, again, we want to say, okay, this is a tissue level implant. And when we're looking at it, we can see gaps along here. So when you're detecting this, you're trying to determine, what can I see this? Is this an issue? Is this cleansable? If I put floss around here, am I going to get trapped and get filaments caught in here? What do we need to do? Change the pros? So this is, again, how you are so important in the maintenance of these, but you have to know what you're looking at, and you have to have diagnostic radiographs. And then, of course, in this one here, this is actually a good one to show you that there's no such thing as bone level because this is a bone level implant, but you can see the buccal is shorter, the lingual is higher, and interproximal could be a whole variance. But again, what we're trying to determine is that the height here is to be at that level of the bone. So here in this particular case, this is a bone level implant. And now it's important to understand that, okay, we definitely have destruction here. But again, do you understand the components here? Can you feel this in here? What do I have any residual in here? What am I going to use in here if I do have biofilm? So again, understanding the importance of the hard mechanisms are key. So this is a great website if you haven't heard it already. It's whatimplantisThat.com. What a great name. And so if you know the companies into which the clinicians are placing the implants, then you can populate it and then start looking and you can see, oh, this is what it looks like. You know, so if it doesn't look like that, then you can bring it to someone's attention and say, can you look at this and make sure it's okay? I'm a little, I'm uncertain here. And then if you do have an implant that shows up in your chair, someone from Italy comes in and you'll say, I can't figure this out. So this site here, spotimplant.com, is a good one because it actually helps you go through to be able to say, okay, well, what kind of implant do I have? Then what kind of connection do I have? What's the shape of it? And so you go through like a flow chart to be able to get to potentially identify, and then you use whatimplantisThat.com to be able to identify it, because you can then populate, here all the things like, okay, so what do I have? The threads, what type of threads do I have? Do I have an apex? What are, all these things like that. So you may or may not be involved in that process, but I do think that it's important that you understand what you're looking at on a radiograph, because again, you're probably going to have more eyes on it than anybody else. And so early detection is the key to it. So just for our soft tissue management, this is where it's really important that we really kind of hone in, and I really circle this to really show you that this area, this perimucosal tissue, is thin, non-keratinized, and fragile. So whatever you're putting in there, whether it's probing, detecting, a hand instrument, an ultrasonic, whatever you're going to put in there, you have to be mindful of this junction, because even in a natural tooth, we have about 1 millimeter of junctional epithelium attachment. So again, 1 millimeter, that's it. And so when we have this circumstance here, we really have to be mindful. And then of course we have connective tissue, of course, like we do with our natural teeth, but it's also very different. And I really enjoy this video as animation here because it really shows these little tufts of that's all that's there. And again, you can see that you're lying right near that crustal. So when you're probing, we can understand why some of our colleagues are still not happy about probing implants. So we can have a conversation about that as well. Okay, so here are the clinical parameters that you can, or I'm hoping, and eventually I can talk to you in another 6 months, and we might have more things to put on there. So the clinical parameters for implants themselves are like it is for natural teeth, but definitely things like the mobility, zero mobility, right? We need to make sure that, and it's something that's, and bleeding, of course, is concerning. And of course, exudate is really of the most concern, because when you have exudate, then indeed it's very specific that you indeed have disease. And so, but things like caries, so we'll talk about that in a few moments here. And what type of deposits do we have, in the sense of biofilm, because obviously that is the etiology to the biological reasons why implants will fail. But onto the conversation of whether or not we should probe or not. I think at this point now, I think we can say, well, again, you can be in different camps. Like I said, it was in California, and when I asked the audience, it's still controversy. Some people are like, absolutely not, will not probe implants. And then I would ask them in the most nicest Canadian way, well, can you please help me understand how you determine the level of inflammation to give a classification of mucositis, for example? And they would say, we take a radiograph. And I'd say, thank you. And of course, in my head, I'm like, I completely don't understand. Like, that doesn't make any sense to me. But I'm always open-minded. I mean, I'm not attached to any one theory 100% because that's just not the way it is in research, right? So we do the best that we can with the knowledge that we currently have. And when we learn more information, then we can pivot. And that's what the rethinking, right? Don't stay too locked into one concept. You really have to be kind of open-minded to have rethink moments as, why do I do what I do? Because I was taught that way, or it's working. And that's true, but maybe it can work better if we do it differently. Okay, so back to the conversation of probe. So in our cassettes, we will have in private practice and at the university, we have metal probes and we have plastic probes. And the most important thing here is that you recognize that when you put equal pressure, so Newton force or grams of force, that when you're using a metal probe, it is very different than when you have a plastic probe. And so this becomes the issue more so than, can you use a plastic probe or can you use a metal probe? So from the literature, there is no concern to use a metal probe to give you information if that's what you're using. You can also use a plastic probe. So there wasn't really any like, you must use this and you must use that. There's just more guidance to say that if you're using a plastic probe, your deviation is so much more. So your accuracy in your pocket measurement may be off. However, if you do not have a cuff of keratinized tissue, let's say in the lower mandibles, it can be very painful for individuals. And so a plastic probe might be more comfortable for the patient. Or if you have emergence profiles and you're like, I don't even know how to get in there. So a plastic probe might be helpful, and you're not really trying to get accuracy in pocket measurements. You're trying to determine the level of inflammation, which is the predictor. So bleeding on probing is definitely a predictor of potentially perimucositis, and perimucositis is a predictor of periimplantitis. So if we don't check, well, we're gonna know. So all the cassettes in your office must be exactly the same, because if you have a variance in your probes, like even all your metal probes, they should be all exactly the same, because they have different diameters that will create different forces. So if you have this metal Marquise probe, you must use 0.5 newtons or 15 grams. But however, if you're using the plastic probe and you use 15 newtons, then maybe you're not probing enough. You have to increase your pressure when you're using a plastic probe. And Premier, the PerioWise, the color-coded one, it seems to be the most common one that individuals have. So you can have both in your cassette, but now you need to know what is the force that you're using, right? With your, so get a scale out. Put it to grams, start doing your measurements and seeing whether or not you know, are you putting too much force? Because unfortunately, the literature does tell us that we get a lot of false positives because we put 2 to 3 times more pressure than necessary. And of course, then you have the risk of false positives, especially for bleeding on probing. Okay, so, and in your documentation, you have to make sure as well, I probed with the plastic probe, I probe with the metal probe. So the next person that comes behind you, they know what these measurements mean, so that you're not saying, oh no, now we have pocket measurement that's increased. Oh no, now we have, you know, a different level of disease. Okay, and then so those of you who are now freaking out because we're putting too much pressure on your probes, you can purchase sensored probes. So you have a lever here and it will make contact with this. This is a plastic probe, of course. And then when this lever makes contact here, you've reached the significant pressure that is specific for this particular probe. So you know you won't exceed if you start making, excuse me, start making contact. And now the concern, because there's always something to concern us in dentistry, is now paint. So if I go back to this image here, the plastic probes, you've probably seen that they discolor. And so now the concern is, well, where does this discoloration go in the sterilization? So try to keep them as clear and no discoloration, because the concern is the discoloration is ending up on the implant surface or the epithelial tissue and irritating, and then we have inflammatory and yada, yada, yada. So something else to be concerned about. So just keep them as healthy as like the colors are nice and clear and not gone through sterilization maybe 5,000 times. And they can break. We've had many times, I don't know what it is with the grad perio students, but they break them. And then now we have to go get them, like subgingivally. Yeah, so be careful. So here's a 90-degree probe that has been helpful for especially things like pros, because again, when you're trying to probe the implant and you're trying to stay aligned with the implant. So you may have to come in on an angle to get around the, the pros, but then when you try to probe, you're trying to realign yourself. So this 90-degree one has been very helpful, and it's also really helpful distals of 7s, distals of 8s. So it's a good one. I have them not necessarily in my tray, but I have them in my drawers sterilized. And then again, but if I use that, that's what I write, that I used a MetaProbe 90-degree angle. Okay, now, as I was saying, the predictor for concerns with perimucositis and mucositis being concerned for implantitis. So this becomes a challenge, because what does the bleeding mean? So no bleeding, I'm very happy. Perfuse bleeding, I'm not happy, but at least I understand. The one in the middle keeps me up at night, because I'm like, well, did I put too much pressure? Is there medication that's influencing this? Is it mucositis? Like, you're trying to help yourself. So I wish there was some kind of guidance that the AAP would have put out. All that they say is use an indice like 0, 1, or 2, but I don't like it. The probe gives us the information, it bleeds or it doesn't bleed, but it doesn't get us further information as to why it's bleeding. So it gives me a little bit of palpitations. So I'm going to encourage you now with your maintenance to start to become this risk assessment. You should have perio risk assessments. You should have caries risk assessments. You should have quality of life risk assessment. And you know what I'm going to say? You should have implant risk assessment. So it's all about understanding that person's level of risk, and then you support to be able to, how do we manage these risks to either prevent them to further progress or how to mitigate them. So this is the game, and it's very individualized to the person, right? It's not the generic approach. For each person gets the same care plan. That's why we do risk assessments. So here are some indices that I think are valuable. So Montbelli started in 1987. Come on. But now we have Dr. French. He's from Alberta. Some of you might know him, and he created this wonderful support to be able to say, okay, if you have level of bleeding, okay, that's important information. But when it comes to implants, bleeding alone is not enough. Exudate is more of a predictor of disease than actual bleeding. So when you actually see in this case here, and some of you may already have this, natural teeth traditionally, unless it's quite severe and there's tons of, infection and there could be an uncontrolled diabetic, okay, you might have some exudate, but you'll have more bleeding than you will have exudate. When it comes to implants, you will have more exudate than you will of bleeding, especially when you have implant infection. And this is what this image really does. And the majority of time, this is what you will see. So having an indice that will help you to navigate that when you add in the incorporation of exudate really can be predictive. So in David's workflow, I guess I'll call it, every time it changes and you have the advancement of suppuration or bleeding at perfuse or moderate. So every time you jump from one to the next, the bone loss doubled with each stage. So as soon as you go from 0 to 1, you're like, okay, we need to act fast. And this would be good information when you're sending it back to whoever was a clinician who placed the implant in the first place. But that's my biggest takeaway for you is really monitor, use your risk assessments to help guide you to know how you're going to manage this patient. And I'm just going to skip now just because I'm looking at the time. When it comes to radiographs, you need to be mindful of the diagnosticness of it. So even this one, I would say, in my opinion, it's not even good, but it's the best I have. Of all the darn implants, radiographs, I was having a hard time finding a really good one a couple of days ago. But anyways, so here you can see really what's important is you need to have crystal clear threads. And sometimes that's difficult, you know, positioning in the mouth, the plates in the mouth, accessibility, you know, choking, all those kinds of stuff. But you'll start to see here that, and sometimes this particular one is absolutely not diagnostics, and you just apologize to the patient and try again, because there's really no point. And in fact, there was a case that went to the college, and it was, you know, the clinician got into some challenges, we'll say, because the person reviewing the case was like, how could you make a diagnostic statement based on an undiagnostic radiograph? Like, you've missed the mark completely. And the rest, you could probably guess what happened. So if you have potentially one side, like if you're taking the radiographs or the dental assistants are, but you can support them, because you'll say like, well, how come I have one side that's clear and the other side it's not? So it's all to do with the angulation. So if you have like diffuse threads that are present on the right side of the implant, then the beam angle was positioned too much to the superior direction. And then of course the opposite, the left side, is the beam was from an inferior angulation. So now you can start navigate to, when you look at your radiographs, to see why is one side. Now you can help yourself go through that. But it is key to have 90 degrees, like bang on, crystal clear, horizontal threads as much as you possibly can. And what's coming down the pipeline is really helpful because these are extraoral, so not intraoral vertical bite wings, extraoral vertical bite wings. So lots of excitement about it. We're not quite there that with the graininess, and if a little bit more challenging to detect caries, but I think the technology is just going to get better. And eventually, maybe now going forward, you know, when we have to look at an implant in particular, now we get the full picture. It might be really beneficial to have extraoral vertical bite wings. The patient just bites on, you know, like a pan, you just bite and then it just goes around and then you're done. So cross our fingers that it keeps going in the direction to be as optimal in its proximal views as much as possible. Okay, now jumping along for time-wise, would you like me to stop here and then they can ask questions, or keep going? Because I just looked up at the time.
Yeah. I have a few questions for you. Let's see. Maybe I'll get to those. Everybody gets their question answered. Sorry, Diane. I have some of the three questions, and then we'll see. What if the client failing to fight chronic infection as long as possible and not extract, hangs to it for years? Do you count the failing then or not?
Okay, so if the prognosis of that tooth is hopeless, but the patient decides they're not going to have it extracted, it is considered part of tooth loss. So any tooth that's still remaining in the dentition is given a prognosis of hopeless, is added to loss of tooth, even though it's still in the mouth.
Okay. With regards to the smoking affecting it, what about smoking cannabis? Do they consider that?
In the literature for the AAP, there was conversations about it, but not. It's not part of that table. That is only for nicotine, like for smoking, for traditional smoking.
Okay. One more. How does not changing grade work with your reduced periodontation? When we talked about reduced periodontium with previous perio.
Okay, I think I missed part of that. So if you can't have both. So I'm not sure I heard the whole question there, but
hold on.
Yeah.
How does not changing grade work with your reduced periodontial patients?
Because if you, okay, so if you have given someone a classification, so someone comes in and you've done your diagnostic, all your clinical parameters, and you have deemed them to be periodontitis stage 3 grade B, okay? So that is the initial, it's just like you've gone in and now you have stage 4 cancer, but along the way now you have stage 2 cancer. It's not to say that the stage 2 cancer isn't relevant, it's just that stage 4 has more precedence. And we know we always have to be mindful of the fact that you are at stage 4. So you could be in remission. And if you are in remission, now in the language that we have for dental, we can say someone in remission can have a reduced periodontium. But you never lose the initial one. We're just adding it to the classification. I hope that makes sense. So we don't ever get lost to the fact that this person had, at what stage that person was, but we are now recognizing that we're moving in a direction of health. And we can say the gingival tissue is now health if it falls underneath the criteria that the classification was given.
Okay. And that's it for the questions that I had noted. So I don't know if you want to end with anything.
And with anything, is that what you said?
Yeah.
Okay. So I think the most important thing to end with, it would be your risk assessments. So here's a really good implant risk assessment that you can incorporate. It is not difficult to do. There might be a few things like, clarification about the restorative margin to bone or the pros, but they're easy. If you read the article, you will understand. So so if you're in the green, you're at low risk. If you're in the yellow, you're in moderate risk. And if you're in the red, that you're at high risk. This is a great communication way to be predictive of whether or not you're going to actually have issues with this implant, and in conversations with whoever's placing the implant as well. And then the next thing when it comes to implants, I'll finish up with this. So when you have a variance of cases like this, where you have everything from peri-implant health to, at a point where like we need to remove this. However, this patient is definitely not interested in taking out half of the dentition in the lower. We have to manage all these different cases. And what do you do? So I'm now just going to jump over to the protocol sheet here, and then we will finish up with that. And if anybody wants to stay behind and ask questions, I'll leave it up to you guys. So here's here's your intervention protocol. So if you've given the classification of peri-implant health, that means there is no inflammation. There is no bone loss past the threads. Therefore, the intervention for it is no treatment. You don't need to do any further periodontal debridement in that area because you've given the classification of health. So you've probed, you've used your 11-12 Explorer, like your FlexPlorer. For me, I'll just jump over here. So this 11-12 Explorer is called FlexPlorer from LM. It is my #1. It is the skinniest, most flexible 11-12 Explorer I have come across. So you've done that. So there is no need to do any further periodontal debridement around a peri-implant health classification. If now, however, you do have an accumulation of biofilm, the biofilm is enhancing the inflammatory process. So when you're probing, you're getting indication that you have some kind of clinical challenge, bleeding or probing, whether it's a dot or profused, but still you don't have the bone level around the implant that's progressing, then you call that peri-implant mucositis. And if you have that, then you'll use mechanical debridement. You will be doing periodontal debridement, but I'm going to encourage you to start thinking about what am I putting in that space? So if you're putting bulky hand instruments in there, that's not the goal. It won't be beneficial because you're not respecting that very thin, fragile, non-keratinized tissue. So you have to be like, what am I going to put in there? So you're like, okay, Penny, well, can I put an ultrasonic in there? And if you put it, so on this side here, this is titanium here, but even so, I would prefer, if you only had the choice between these two, then I would use, the ultrasonic. But remember, these materials are not meant to go on the threads. And we have to be careful about this because when we look at the literature, we see these particles being submerged into the topography of the implant. And many times the implant companies will have these micro threads that go all the way up close to the abutment so they can get as much bone all the way up. So if we're putting this down 3 millimeters, we run the risk of these materials, the peak materials here, doesn't matter which one, onto those. You can also run the risk of having these on the implant surface as well, on those micro threads closer to the implant. However, we sometimes have to do things when we have things like this, like, you know, residual resin that is there. And we have to contend with this to be able to get some kind of resolution. So my goal then for you would be to invest into titanium instruments, and then also from Acteon, these are titanium ultrasonic, but they're piezo, not magneto, which most people use magneto. But so that would be your kind of intervention protocol when it comes to perimucositis. You're just trying to manage that perimucosal tissue to have biologically compatibility again. However, now if you have periimplantitis, you can take all the options, throw them in a bag, shake them up, and then pick one, because that's truly is your your level of success is equal in any one of them. We do not yet still have a very high treatment success rate. So placing an implant, high success, yes, indeed. But if something happens and we have to treat, we don't have a high success rate, especially when it comes to peri-implantitis. But there's things that are coming. Here's GalvoSurge, and that's the last thing I'll say, and we'll end with that. So Nobel Biocare is coming out with this GalvoSurge, and it uses electrolytic approach. So it kind of uses these ions, like it shakes it up like an ultrasonic, and then no matter what implant surface, and then it ends up looking like that. So we'll see how good it is, and I'm sure we'll be doing research at the university. So I will end with that, and here you go in case you want to reach out. So when the email gets sent to you, there is a case in there. So go ahead and work it out. And if you've got questions, feel free to ask.
You're awesome, Penny. I think everybody loves you. So we might have to have you back.
Yeah.
Sorry. I just have one question. Somebody's asking about what about air powder polishing on an implant?
Absolutely. So make sure that we're talking the same language. So when you say air polish, I'm hoping that you're referencing this, and that you're talking about technology that allows to be able to, so not like a ProfiJet would not be appropriate to be on a surface of the implant surface. So, and I would be concerned with sodium bicarbonate on any kind of pros. So you just got to make sure that you got clearance. If I did that, so we're in a perio-pros office. So I had to make sure whatever I was using was not going to change any kind of luster or beautifulness of the pros. And so if you're talking about this kind of technology, 100%. And we've done a lot of research at the university to support that. So these are all diseased implant surfaces, and it was quite remarkable to see. But again, this is with powders that are erythritol and glycine only, no sodium bicarbonate on pros or the implant surface.
Amazing.
Okay. Yeah. Okay.
You get to rest now.
I'm all fired up.
I know what's happening. I'm like stating that you're full of energy. I'm gonna have I'm sorry about the echo, everybody. Totally out of my hands. I know it's horrible. Stop talking. And I will email you all next days. Okay. Thanks, Penny. Thanks, everyone.
Thank you.
Bye. Everybody.
All right, should I go ahead and end?
You go right ahead.
Okay.
You earned it today. Miller's
Thanks.
fun.
All right. Thank you.
Okay, and I sent you an email, so I'll chat with you soon.
Okay. All right.
Okay,
Bye for
bye.
now.